Hi, my name is Sunil Rama and I'm a chiropractor and I'm going to be talking about adhesive capsulitis or frozen shoulder. Now, as the name suggests, adhesive capsulitis is adhesive as in sticky and capsulitis as in inflammation of the capsule within the shoulder joint. These patients usually present as females. We do see males as well, but we see a much stronger prevalence of females that have either diabetes or a hypothyroidism, patients that have had any shoulder injury in the past. And what we find is that after the injury, or for some systemic reason, the patient has a lesser blood flow to the area in the shoulder that requires adequate healing. And it does so in a very haphazard manner. So the healing component to that shoulder starts becoming lesser, and the patient start getting shoulder stiffness. And the typical presentation is shoulder stiffness where they may not be able to put the bra on, or combing hair becomes difficult, or reaching overhead for a cupboard becomes difficult. And they've got ranges of motion that follows a fixed pattern. So for example, with frozen shoulder or adhesive capsulitis, your typical movement that becomes affected is the hand cannot go into the small of the back. So turning the entire hand inwards becomes very limiting to the patient. The second is the patient taking the arm all the way upwards. The third would mean the patient has difficulty moving all the way upwards in the frontal plane. And lastly is patients going all the way across or outwards. Now, it doesn't follow that pattern in all cases, but in 95% of cases, the hand in the small of the back becomes a huge issue. And this is what usually makes the patient present to their practitioner for some form of assistance. And we usually divide this condition into three phases. We call it a freezing phase, a frozen phase, and a thawing phase. And the freezing phase is where the patient starts slowly losing mobility over their shoulder, where they can no longer do what they used to do. That usually takes about 6 months. The second 6 months is the frozen phase, where the patient has no mobility in that shoulder. And the last is the thawing phase, is now when the patient starts getting better and getting the range of motion back in again, and the shoulder starts to free up and ease up. And this is where the patient starts getting the maximum benefit. However, from a treatment point of view, we have to try and minimize the frozen phase to make sure it doesn't occur, if at all, and try and get the patient into the thawing phase just after the freezing phase, so sort of cutting out the middle 6 months. It is a lengthy condition, and nowadays you get numerous protocols of treatment that may help and facilitate a better outcome, like your injectables. But our main protocol of these patients is getting that shoulder to move with caution. So too much too soon can often get the patient feeling worse off. And what we want to do is give these patients exercises to make sure that the shoulder starts moving so that the brain can still establish some range of motion that needs to take place into the shoulder. Otherwise, you just go into an inhibition where the pain becomes so bad that you keep it into a sling position. And that protocol is now proven to make patients have a lengthy outcome, and the patient's pain just tends to prolong. So we try and get those patients mobilized with caution, of course, in the shortest space of time. And the last movement that the patient tends to get back to normal is, like I said, the hand in the small of the back. So it's the first motion to go, but it's the last motion to get back in again. Usually they can progress, and we'll see progress and improvement with getting the shoulder upwards and getting the shoulder upwards in the frontal plane. But the hand in the small of the back usually takes the longest. We also find a strong neck correlation towards patients with shoulder discomfort, where the neck muscles become tight. Then we start finding patients getting pain down into the elbow. The elbow pain and the neck pain is usually a direct referral from the shoulder. Of course, we need to rule out if there's any pinched nerves or any disc or nerve fallout that may cause some of the patient's shoulder pain. It's the one condition where we're not overly keen on requesting any MRI scans or requesting any X-rays, because the diagnosis is mainly on clinical presentation, as I have suggested. It's in those very long-standing conditions where we find the patients making no progress at all, that we may resort to an MRI of the shoulder just to make sure that there's no significant tear of one of the tendons that may have taken place. Nevertheless, as debilitating as this condition may be, we see very good outcomes in the modern day, and patients usually present very early for treatment. And at my practice, I see favorable outcomes because we tend to use ultrasound, electromodality, some dry needling, and careful shoulder mobilization to get the patient back up and running in the shortest space of time. Thank you so much for watching the video.